Local anesthetics are the drugs that act locally, that is when they are given by either a topical route or by local injection, so act in a restricted area. And anesthetics means there is loss of sensory perception, and that too especially of pain. And very important aspect with the local anesthetics is that there is no loss of consciousness. So this is in contrast to the general anesthetics. With local anesthetics, there is no loss of consciousness and person will be awake during the procedure, whatever procedure is done with the local anesthetics. Now, what are the different types of local anesthetics? All local anesthetics have one hydrophilic end and one hydrophobic end, and these are connected by either ester linkages or amide linkages. And based on this linkage, which linkage is present, whether it is ester or amide, we have ester linked local anesthetics and amide linked local anesthetics. So in the ester linked local anesthetics, we have cocaine, procaine, chlorprocaine, tetracaine and benzocaine, while in amide linked local anesthetics, we have lidocaine, bupivacaine, dubucaine, prilocaine and ropivacaine. And simple way to remember, if you see, all are ending in cane, and this amide linked LA, the name has double I. One is in cane and another I is present in their names, while ester linked LAs, their name only has one I. Now this ester linked LAs, they are metabolized by plasma pseudocholinesterase, and because of this they have very short duration of action, except cocaine. Cocaine is metabolized in liver. Amide linked LAs, they are metabolized by liver and their duration of action is long, intensity of action is also long. And with ester linked LAs, there are high chances of hypersensitivity reactions. On the other hand, with amide linked LAs, hypersensitivity reactions are uncommon. So obviously, because of this hypersensitivity reaction and short duration of action, less intense of action, majorly used LAs are not ester linked LAs, these are amide linked LAs. Now, what is the mechanism of action of local anesthetics? So local anesthetics basically block the generation and conduction of the action potential. So this diagram is showing a typical action potential of a neuron, where we have the rising phase, that is the depolarization phase, and then we have the repolarization phase. In depolarization phase, resting membrane potential changes towards the positive side, and repolarization is when the potential comes back towards the resting membrane potential. Now, depolarization phase is due to opening of voltage gated sodium channels. Now, here is a schematic diagram showing the voltage gated sodium channels. So, at RMP, these voltage gated sodium channels are closed. So, here you see this voltage gated sodium channel has two gates. This is the outside gate, that is known as M gate, and this inside gate present on the intracellular side is known as the H gate. Now, when there is a stimulus, these voltage gated sodium channels open with this M gate opening up, and then automatically they inactivate. So as they open very fast, they inactivate. So opening is due to movement of this M gate, while inactivation is due to movement of this H gate. You see, in closed state this H gate is open, but from open to inactivated, this H gate, it closes the pore of the channel. Okay, so three states: closed, open and inactivated. Now, our local anesthetics block this sodium channels in the inactivated state, and it's very important that sodium channels move from inactivated to the closed state, and that happens only during repolarization. Understanding? So you see here, the voltage gated sodium channels open, then they become inactivated, and they become closed again only when the membrane potential comes back to resting membrane potential, and only from closed state they can open again. Right? So for the new action potential generation, we want this inactivated sodium channels to come back to closed state, but our local anesthetics will kind of fix these channels in this inactivated state. Okay, so how is this happening? So this is the local anesthetics. Actually, local anesthetics are weak bases. So this is the base, and this is the undissociated weak base. So this weak base in undissociated state crosses the cell membrane, because then it will be lipophilic, it can cross the cell membrane, and once it crosses, it again dissociates into its ionic form, and then it binds to that binding site present on the H gate. So actually local anesthetics act from the intracellular side. They have to enter into the cell membrane and act internally, right? That is one thing. Second thing is that binding site affinity for local anesthetic is more in open and inactivated state. It cannot bind in the closed state. So even if the local anesthetics enter into the cell, it cannot bind to this H gate, the binding site on the H gate in the closed state of the channel. The channel should be either in open or inactivated state. Then only our local anesthetics will be able to bind to their binding site. So two things we come to know here, that LA enters in undissociated form, and second, it binds to the channel when the channel is open or it is inactivated. And this is important because later we will see that the degree of block of this channel depends on various aspects which determine how much local anesthetic is going to enter into the cell and whether it is binding to its site or not. So now by binding to these channels, by fixing it in inactivated state, basically it will block the conduction of the nerve impulse, because for conduction we want the action potential to be generated at nodes of Ranvier in myelinated nerve fiber, and in unmyelinated nerve fiber in fact it is generated very close, it is regenerated again and again. So if sodium channels are not going to be open, they are being blocked, then there will not be any conduction of the action potential, and hence this will block the transmission of any signal and thus leading to anesthesia. So what are the factors which affect the degree of block? That means how much intense the block will be locally. Here we are talking about the local action where the drug is given. So one is myelination, where the block is faster in myelinated fibers compared to that of the non-myelinated fibers, and the next is fiber diameter. And actually if you remember from your physiology, Erlanger-Kayser classification classified the nerve fibers as A alpha, A beta, gamma, delta, then B and C fibers, and from top to bottom, from A to C, these are the fibers of decreasing diameter. So A alpha has maximum diameter and C is having the least diameter, and this A and B are myelinated fibers while C is unmyelinated fiber. So if we see that which fibers will be blocked first, we have said that myelinated fibers are the first to be blocked. So B fibers will be blocked first, and then we are going for the diameter, that is the least diameter will be blocked first. So we have B, then we have C, and then we have A delta, then A gamma, beta, and finally we have A alpha. So going back to here, what are the sequence of block? We have autonomic fibers which are blocked first, then sensory fibers, and then motor fibers. So again you see in Erlanger-Kayser classification, these fibers have different function. B and C are autonomic fibers, A delta and C is the pain fibers, and also A delta is temperature fiber. Then A beta, ta for touch, okay, that is touch and pressure, we have A beta fibers, and A alpha is for proprioception. So if we go like that, then autonomic fibers will be the first to be blocked. C fibers, that is the pain fibers, will be the next to be blocked. Then we have temperature, okay, so pain, temperature, then touch and pressure, and finally we have the motor block. Motor is which fibers? Motor is A alpha, alpha motor neuron, that is motor fibers. So they are the last to block. Now there are certain local anesthetics which give this differential block more than that of the others. That means in a dose, in a particular dose when they are used, then this differential block, that means sensory much before than the motor, we get with certain local anesthetics much more, and that is used in certain clinical cases that we are going to see later. Okay. Second thing is the fibers which are first to block are the last to recover. Okay. Second thing is whether the nerve is resting. See, resting nerve means the channels are in closed state, and we have seen that the affinity of the receptor for the local anesthetic is least in the closed state. So this resting nerve is resistant to blockade. In fact, if we increase the frequency of stimulation of the nerve, then that nerve will be the fastest to be blocked. Okay. Then third is the pKa of the local anesthetic with respect to pH of the body fluids. Now I have told that these local anesthetics are weak bases. Now lidocaine has pKa of 7.6 to 7.8, and the pH of body fluids is approximately 7.4. So this pKa of the lidocaine is approximately same as that of the pH of body fluids, and when the pKa is same as pH, then approximately 50% of the drug is ionized and 50% of the drug is in non-ionized state. And we have seen before that it is in the undissociated form, that is in the non-ionized state, that the drug is going to cross the cell membrane, and when it crosses the cell membrane, then only will be able to bind to its receptor site, which is intracellularly. So we want more drug to be in undissociated state. So more the lipid solubility, that means when the pK is almost equivalent to pH, then more drug is going to enter into the cell. It will be directly proportional to potency of the drug, onset of action of the drug, that means there will be faster onset of action, and also duration of the drug action will also be more. But there will also be increased toxicity, because that drug, if it enters into the blood vessel, then in other areas also, other tissues also, it will enter faster. Okay, that we are going to see toxicity later, right? So lidocaine is one such drug which has more potency, faster onset of action and more duration of action. In comparison, we have procaine, tetracaine, bupivacaine, whose pK is much more than the pH. That is, it is more alkaline pKa, and that is why it is more in ionized form. Okay. So we have slower onset of action for these local anesthetics. Then moving on to other factors. So one is location of fibers in nerve trunk. Now see, this is the nerve trunk and this is the skin, suppose, and you have injected the drug here. Now for the action onto the neurons, this local anesthetic will cross this membrane and enter into the nerve. Nerve is what? Nerve is basically a bundle of neurons. So it is going to enter into this nerve, and the nerve is having lot of sheaths. Okay, the outer sheath is epineurium, then there is perineurium, and finally we have endoneurium. So the anesthetic should cross these sheaths to reach to the neurons. So the inner neurons which are there, inner neurons in this nerve, they will be affected later because the local anesthetics will reach to those neurons later. Okay. Then there is presence of inflammation. So when inflammation is there, pH of that area decreases, so it becomes more acidic. So in that case, pK of the local anesthetic will become much more than that of the pH, because the pH has decreased in that area. So drug becomes more in ionized form. So there is slower onset of action. The potency also decreases. Okay. For example, if you are performing a tooth surgery, you are removing the tooth, say suppose, and in case if there is inflammation also, in that case the action of the local anesthetics will be much lesser because the pH of the area is lesser. Then second reason is increased blood flow to inflamed area. So because of increased blood flow, local anesthetic will enter into the blood flow and will be washed off from the region of the infiltration where the LA has been given. The next factor which affects the action of local anesthetics is blood flow. If blood flow is more, there will be decreased local action, because duration of action actually depends on the time of contact with the nerve. You have given the local anesthetic and the local anesthetic is entering very fast into the blood vessel. So that means the amount of local anesthetic which remains in the area is less, right? To prevent this, we have one strategy where local anesthetic is given along with a vasoconstrictor, in this case adrenaline. So this is a combination, adrenaline plus lidocaine is given. So adrenaline will cause the vasoconstriction, causing the local anesthetic to remain at the site of injection. So this is going to prolong the duration of action and also the intensity of blood, and it is also going to decrease the toxicity because LA is not going into the blood vessel, and hence the rate of entry into the blood is lesser, so the rate of going into the various tissues is lesser, and in fact the entered LA will be metabolized by the liver. If it is going too fast, then the metabolizing capacity of the liver may be overwhelmed. There will be accumulation of the local anesthetic in the blood vessel and in other tissues, causing toxicity. However, when this adrenaline is given, it may also cause some side effects, that is delayed wound healing, increased chances of local tissue edema, increased chances of necrosis. And that is the reason that this combination of adrenaline and lidocaine is contraindicated in case of regions which are supplied by end arteries. Okay, and that is the peripheral regions, that is finger, toes, nose, pinna and penis. So in these 5 regions, the combination of adrenaline and lidocaine is never given. Fine. So that is one thing what happens with vasoconstriction. Another thing is that this adrenaline may enter into circulation, and this itself may have side effects like causing hypertension, causing arrhythmias. So in susceptible individuals like uncontrolled hypertension, people with heart disease, again this adrenaline lidocaine combination is not given. Right? So what are the systemic actions as given in KDT? Actually, these are not systemic actions per se. These are the actions which happen will cause toxicity. So when there is increase in local anesthetic concentration in the blood vessel, it will go into other tissues, and there also it will lead to less action potential generation. And because of this same effect, that is decreased action potential generation and conduction of the impulse, toxicity occurs. So first one is in CNS. In CNS, initially there is excitation, then followed by depression. Okay, excitation occurs because there is decrease in action potential generation first in inhibitory neurons. So first inhibitory neurons are affected, so that is why there is excitation. Then there is depression. So the symptoms include initially circumaural numbness is there, blurred vision, tinnitus, drowsiness, lethargy, then restlessness, agitation, twitching, seizures. So this is the signs of excitation, and then the person will ultimately land up in coma. So treatment of the CNS toxicity, see, we have to identify the initial signs like circumaural numbness, blurred vision, and then start the treatment as soon as possible. That is, we have to give airway, breathing, circulatory support, and we have to give intravenous benzodiazepines. Benzodiazepines can prevent the seizures as well as treat the seizures as well. Okay. Then there is a toxicity to the heart. When this toxicity to the heart appears much later than that of CNS. So 2 to 3 times increased dose of local anesthetic more than what can lead to CNS toxicity will lead to heart toxicity, except in case of bupivacaine. Bupivacaine cardiotoxicity is much more, and approximately at the same time when CNS toxicity symptoms are appearing, CVS toxicity symptoms will also appear. Secondly, if inadvertent IV injection is given, then also we will get this CVS toxicity much earlier, right? And what are the manifestations? We have cardiac depression, arrhythmias, and remember that CNS toxicity is easier to manage, but heart toxicity, it is much more difficult to manage. Okay, so antiarrhythmics need to be started, and there is actually IV lipid emulsion. IV lipid emulsion needs to be given, and this IV lipid emulsion basically removes the drug from the areas, right? Then we have the blood vessels. In blood vessels, again, decrease in action potential generation. It will lead to decrease in muscle contraction, leading to vasodilation. This will lead to cardiovascular collapse. Exception for this is cocaine. Cocaine is sympathomimetic, and that is why it can lead to increase in blood pressure rather than decrease in blood pressure. Then hypersensitivity reactions, we have already seen that with ester linked local anesthetics there can be hypersensitivity reaction, or if preservatives are added to local anesthetics, so there can be hypersensitivity reaction to these preservatives, right? So those were the toxic manifestations of local anesthetics. And what are the factors which affect toxicity? First one, I told you that there can be inadvertent IV injection, that we have to be cautious in that. Whenever we are giving local anesthetic, we always have to aspirate to ensure that the injection is not going into the blood vessel. Okay, so that is inadvertent IV injection. Then what is the plasma protein binding of the local anesthetic? More the plasma protein binding, that means lesser free local anesthetic concentration, and it is the free concentration which is going to cross the plasma membrane and will cause toxicity. So more plasma proteins means less toxicity. Liver disease. Liver disease means our local anesthetic will not be metabolized as fast by the liver. So that means it will accumulate in the circulation and will cause toxicity. Decreased cardiac output is another reason, because this will lead to decreased blood flow to the liver and hence decreased delivery of local anesthetic to the liver. So these are the factors which affect the toxicity. And for preventing the toxicity, what precautions we have to follow? Well, never exceed the maximum dose. Always aspirate before injection, because we have to avoid giving IV injection. Then when we are using the combination adrenaline with local anesthetic, I told you not used in 5 peripheral areas which are supplied by the end arteries. Avoid in ischemic heart disease, cardiac arrhythmias, uncontrolled hypertension, thyrotoxicosis, patient on beta blockers, because again this predisposes the patient to arrhythmias, and patient on tricyclic antidepressants. Then caution in patients with liver disease with amide linked local anesthetics, because these amide linked local anesthetics are metabolized in liver, and in liver diseases that metabolism will not be that much and even lower dose can be toxic. Then moving on to the individual local anesthetic drugs. So we are going to discuss some important points about that, not fully. So first is lidocaine. Lidocaine is a very commonly used local anesthetic. It can be used topically. It can be used for infiltration where it is given subcutaneously in a particular site. We will see what are these blocks. We will see little later. It is used for field block, nerve block, and this lidocaine is having fast onset, intense local anesthesia it provides, and it provides long lasting anesthesia, that we have seen that its pK is much closer to the pH of the body fluids. Then lidocaine can also be used as surface anesthesia, that is for intact skin. Here when we are talking about topical, it is used in for mucous membranes and abraded skin. But surface anesthesia means that on the skin, on the intact skin, we provide an occlusive dressing of a mixture of lidocaine and prilocaine. So 2.5% lidocaine, 2.5% prilocaine occlusive dressing is available. This is given approximately 30 to 60 minutes before a procedure. Okay, 30 to 60 minutes before, say suppose for venipuncture. So before that if we give, it will provide an anesthesia for a depth of 5 millimeter. Okay, so we are not giving infiltration, we are not injecting, but just by occlusive dressing, the drug will go inside into the skin and provide the anesthesia for a depth of 5 millimeters. Okay. Then we have bupivacaine. Bupivacaine, I told you that it is more cardiotoxic compared to lidocaine. It is never given IV. Okay, because we'll see later that there is a type of anesthesia that is IV regional anesthesia. Bupivacaine cannot be given IV. Then its pK is much more than pH, so it is having slow onset of action. That is why it is not used for peripheral nerve block. It is used mainly for spinal and epidural anesthesia, and it is also used for continuous epidural analgesia. Then we have ropivacaine. Ropivacaine is again used epidurally and it is less cardiotoxic than bupivacaine. Then we have propracaine. Propracaine is most common used ophthalmic anesthetic. Then we have Dubucaine. Dubucaine is most potent, longest acting and most toxic local anesthetic, that I told you before, that lipid solubility will determine the potency, duration of action and toxicity as well. So that is why this Dubucaine is most potent, longest acting but most toxic as well. Then lidocaine. Lidocaine is also used as antiarrhythmic for ventricular tachycardia. So yes, it's a local anesthetic, but it is also used as antiarrhythmic for ventricular tachycardia. Then there are certain local anesthetics for whom the side effects is methemoglobinemia, and that includes prilocaine and benzocaine. So when these drugs are metabolized, there is a toxic metabolite formed, that is O-toluidine, and this is responsible for methemoglobinemia. Then bupivacaine, I told you already that it is much more cardiotoxic than other local anesthetics, so it is never given IV, so it is not used for IV regional anesthesia. And then we have prilocaine. Prilocaine is a drug of choice for IV regional anesthesia. So with this, let us move on to the types of the nerve blocks which are used. So local anesthetics can be given by various routes, and in the different routes, the area which is anesthetized is different. So when we want a larger area to be anesthetized, we cannot give injections locally for some nerves, maybe by infiltration. If we give, then how can we anesthetize larger area? In that case, we will need to use large amount of drug, which can be toxic. So in that case, we choose different routes. So what are the various routes by which it can be given? One is by topical route, where it is applied to the mucous membranes or the abraded skin areas. For example, in case of ulcer, there is transdermal patch of lidocaine available for post-herpetic neuralgia. It can also be used for perrectal examination. Then it can be used for anal and genital pruritus and other acute and chronic skin conditions. And then we have infiltration. In infiltration, the drug is given by subcutaneous injection, and in infiltration, we need not know that where the nerve is rising, where it is going. We are simply giving subcutaneously, and whatever nerves are present in the area, all of those nerves will be blocked. So that is infiltration. Another is field block. In field block, what we do is we inject in the particular course of the nerve. So anatomical knowledge of the nerve should be available. So say suppose this is the nerve and these are the branches of the nerve. So we are blocking a particular branch of the nerve. So the area supplied by these branches will be blocked. So that is field block. Then we have nerve block. In nerve block, we are blocking that particular nerve as such. So for that, we have cervical plexus block, brachial plexus block, intercostal nerve block, sciatic and femoral nerve block. So obviously, when we talk about nerve block in comparison to field block, the area blocked will be much more, because then all the branches which are supplying a particular area, all will be blocked. So directly by blocking different plexus, entire area which is supplied by that nerve plexus will be blocked. For example, intercostal nerve block is used for anesthesia and relaxation of anterior abdominal wall. On the other hand, cervical plexus block can be used for the surgery of the neck. So here when we are talking about surgery, there will be anesthesia and it will also cause the motor block as well. So that is required for performing the surgeries. Then sciatic and femoral nerve block can be done for lower limb surgeries distal to knee. So those were the topical, infiltration, field block and nerve block. Now in between the topical and infiltration, we have another route, that is occlusive dressing is there, which is basically a eutectic mixture of 2.5% lidocaine and 2.5% prilocaine, which we have already talked before only. This is the only method where the anesthesia is applied on the intact skin. In topical, we said it will be either on the mucous membrane or abraded skin areas. With EMLA, it is applied on the intact skin, and the local anesthetic penetrates into the skin up to 5 millimeter depth, and this is done approximately 30 to 60 minutes before the procedure which we have to perform. For example, before venipuncture, before skin grafting. So this method is providing anesthesia below the skin but without any invasive method. Then we have spinal and epidural anesthesias, and these are given when a large area needs to be blocked. So spinal anesthesia, it is given between the arachnoid mater and pia mater, and actually the spinal cord ends at level L1 of the vertebra, and below that we have only the nerve roots coming out which are floating in the CSF. So if we give the local anesthetic between arachnoid and pia mater, then it will anesthetize all those nerve roots which are below L1. So this is used for lower abdominal surgeries, lower limb surgeries, gynecological and obstetric procedures. Epidural anesthesia, on the other hand, is given between dura and bone. So we are not going deep, we are not crossing the dura, it is given between dura and bone, and it blocks the nerve roots. And one important advantage of epidural anesthesia, actually bupivacaine is commonly used for epidural anesthesia, and it provides differential block. That means sensory is blocked much before the motor nerves, and it is used for painless normal labor, so that the motor nerves can continue working and there is contraction of the muscles. On the other hand, the mother doesn't feel any pain. It is also used for continuous epidural analgesia for post-operative pain. See, spinal anesthesia cannot be given again. Once it is given, the surgery has to be completed during that time. On the other hand, epidural, one big advantage is that epidural anesthesia we can give continuously by placing catheters in the epidural space, and this local anesthetic can be given continuously. So that is used for relieving post-operative pain, and it helps in early ambulation in many surgeries. For example, a patient has undergone hip surgery. You want pain to be relieved and then only you can ask the patient to walk. So it will facilitate early ambulation, which is good for recovery. Then apart from this, we have one more block, that is IVRA, intravenous regional anesthesias. So this is used for short duration surgeries, mainly on limbs, basically the hand, wrist, forearm, foot, ankle. That means the areas below the elbow and below the knee. So in this, basically, in the upper limb, in the proximal limb, a cuff is tied and pressure is raised to above systolic blood pressure, so that the region where the surgery has to be done, there is no arterial inflow. So it provides an area, bloodless area for surgery, and there, in the area where the surgery needs to be done, local anesthetic is injected. So this is what is intravenous. So till now we were not talking about intravenous anesthesia because we said that if it enters into the circulation, it can cause toxicity. But because we have a tourniquet, the local anesthetic cannot enter into the systemic circulation. It will remain in the area where surgery is being performed. But again, bupivacaine cannot be used for this because even mild amount, if it enters into the circulation, it is highly cardiotoxic. So those were the various routes of administration of local anesthetics, and with this we finish our lecture on local anesthetics. And like all other pharma videos, the video notes of this lecture will be available for free download from the app. Thanks for watching the video. If you liked it, do press the like button, do share the video with others, and don't forget to subscribe to the channel Physiology Open. Thank you.